Thank you, Dr. VN, and thanks, Dr. Bansi and the team. Today I'm proudly presenting, having the privilege to invite a clinician, an educator, and a researcher in hypertension. In fact, we can safely say that he is the first in the last name as far as the hypertension is concerned, as far as the globe is concerned. He is Dr. Venkat Ram, graduated from Osmania University, Hyderabad, and then trained at USA, Brown University, and then at Pennsylvania. He served as a director of hypertension clinics of Parkland and Dallas. He is the founder member of American Society of Hypertension, from where, in fact, he started from zero, American Society of Hypertension, ultimately landed up by getting bestowed the Mosler Award, which is the Lifetime Achievement Award by ASH. At present, he is affiliated as a director of Apollo Institute for Hypertension Management. He is also the professor of Apollo Medical College. He is director of World Hypertension League, that is South Asia region, at Hyderabad. He is also professor of clinical medicine at University of Texas Medical Center. He is director of Texas Hypertension Institute. He is dean at Sydney McGregor University. Apart from this, he also has 360 publications to his name and 4 books to his name. And one can say that he is one of the most recognized or the topmost hypertension expert in the world at present. And we must be really proud of having him as a speaker for this important lecture. He has also been bestowed the second most respectable award from Indian government, that is Padma Shri, for his work in hypertension and in prevention of heart diseases. He has already said he has already been bestowed upon by Mosler Award, which is the Lifetime Achievement Award by American Society of Hypertension. Surprisingly, he was the youngest, remember, he was the youngest person to be a master of American College of Physicians. So now we can judge who is going to speak next. Dr. Venkat Ram is going to speak next, and he is going to talk about why macrovascular disease is, especially the cardiac disease, is more frequent in patients having diabetes. So not taking much of the time. Really, once again, sir, I'm very much proud to invite you on this dais, Dr. Venkat Ram. Please welcome, sir.
Thank you. I'm sharing the screen.
Before he presents, Dr.
Can you see the screen?
Sorry, sir. Before you start your presentation, we would like to have the citation for Dr. Venkat Ram, which we will be sending to your Hyderabad office rather than your US office.
No, I'm coming. Actually, I'm in Hyderabad only, but please do that. Please do that.
Hardik, please share the screen.
Just a moment, sir.
Hardik, is it getting delayed?
And it is very rare for us to have such a huge faculty with us.
I can, if you all want me to start, I can start.
Just a minute, sir.
Sir, there is a
Hardik is sharing the screen.
Just wait for a few seconds more. I am sorry for that.
He can start, Dr. Bansi is saying that he can start orally till the presentation is available.
With Dr. Venkat, you can start sharing your screen.
Okay. Can you see my slides?
No, sir. You have to share the screen.
I'm sharing them.
No.
I was sharing them. How about now?
No, sir.
Oh. Wow. It's, I'm very much sharing them. I don't understand.
Sir, I think
It's already in the back. Can you see it now?
No, sir.
No, sir.
No.
Stop sharing. See,
Stop
there
sharing
must
it
be.
again and then you again do it.
Okay, I don't understand, but we will. Let me try to just hold on 1 second. It is already there. Can you see now?
No, sir. Sir, are you
No.
seeing your screen sharing has been paused? Are you seeing that something over there?
I see my slides and I see Sabu.
Can you go to the Zoom window and stop share and then share it again?
Okay, all right, okay. Then let me do one thing.
So could you just minimize your presentation and see the Zoom screen?
Do we have his slides?
No, sir.
I think he is trying to re-log in.
Hardik, till that, can you share the citation?
Yes, sir. I'm just sharing.
Hardik, could he join again?
Sir, I'm just trying to call him.
So as Dr. V.N. Shah was remembering Dr. Shrenik Shah, till that we can have Dr. Urman Durve, if you want to share some of your memory for Dr. Shrenik Shah. Every time, I try to ask Dr. V.N. Shah to chair this important session of Dr. Shrenik Shah Memorial Talk.
No, I'm very happy because when
Dr. V.N. Shah,
yeah.
and lately he became very close to me also.
Yeah.
And we were together just before 1 week of his death. We were together with his wife at Dr. Jyoti Dev meeting. So actually Jyoti invited me for his meeting, and I told Dr. would you like to accompany me? And then we were together there, and that weekend we were there on Saturday, Sunday, and the next week he was not there with us. On the next
But
Sunday.
see, a lot of memories are there. You see, yourself, Dr. Urman, then Shrenik, Dr. Sanjeev Phatak, even all we work together in one institute.
All are there with digital.
Yeah. So you are there. So that's why I'm always admiring you. Okay, on one platform, at least a lot of.
Remember Dr. Arab Shah, Bibi Trivedi,
yeah,
and even.
Now, heads off you. That's why, because you say you are already having the Dr. R.M. Shah Hall and Dr. Bibi Trivedi, because ultimately they were the pioneer to at least start the diabetes activity.
Dr. Suman Shah was pioneer in starting diabetes clinic in Ahmedabad.
Yeah.
Dr. Venkat,
We always ask Dr. Premal Thakur to chair the Suman Shah oration. It's always there from the day one, you know. He was the most close one with Dr. Supansha and with Dr.
I
also. Yes, Dr. Urban Bhai. I think you are unmute. You have to unmute.
I always used to trace or follow the prescriptions of Dr. Premal Bhai when I was a resident because I knew him. And from the prescription, I could say that the number of or the amount of metformin that he had used when metformin was banned in USA was much more than the metformin USA, the whole USA started using after that. So the drug which they were banning was being extensively used by us. So we were always little bit ahead of US or the Western countries for that matter.
Today also there was Dr. Premal
Even
Bhai.
that way he was the first to.
Dr. Premal Bhai is there in the in panel group. Dr. Premal Bhai, you can unmute yourself. We get Dr. Venkat now. Hardik, I think we have to.
Sir, Venkatram joined and again dropped off. I'm just trying to get him in again.
Until that, I mean.
Bansi, you can ask him to email the presentation even now. Then Hardik can share it.
Yes, yes. Hardik, that we can do also. Should I call him again?
Yes, sir.
I'm
not picking up.
I'm calling him.
Dr. V.N. Shah, you are all talking about Shenik. He was assistant professor in my unit.
Yeah.
After MD.
Yes. No. Ashaman, you are
nice person. Yeah.
Yeah.
Can I share now? Let me again
Yes,
try.
sir. Yes, sir. Yes, sir. Sir, just click on share screen.
It's not allowing me to click share because others are speaking maybe. Oh, okay. Now let us try.
Yeah. Yes, it is.
Now?
Yes.
Now it had come, sir. Now it had come. Okay. Make it on full screen and now it is.
Okay. Okay, so it's better now?
Yes, perfect.
Okay, I we can't explain the technology thing, but let's move forward. First of all, let me thank the organizers, especially Dr. Bansi Sabu, who is such a great academic person in clinical practice and who imparts medical science in India much more than heads of the department at Vellore or All India Institute of Medical Sciences or other colleges. So it's really a great privilege for me to be with him. He has asked me to speak on why diabetic patients are more vulnerable to cardiovascular disease. And I'm going to show you at least my viewpoint. As all of you know, since you treat so much of diabetes, that once you make the diagnosis of diabetes, you have already made the diagnosis of cardiovascular disease. So once you write in your medical record, the patient has diabetes, basically you also have inked the diagnosis of cardiovascular disease. All of you know that high blood pressure increases cardiovascular risk. All of you know that diabetes increases cardiovascular risk. But when you combine them, blood pressure and diabetes, there is a geometric increase in cardiovascular risk. That means 1 + 1 does not become 2, but 1 + 1 becomes 4. So a patient with diabetes and hypertension is extremely vulnerable for cardiovascular disease. This is a very old slide I'm showing to show that this evidence has been building for last so many years. And this is the incidence of coronary artery disease mortality when you have normal glucose tolerance and when you develop so-called borderline or indeterminate glucose tolerance, and then you have frank type 2 diabetes. You will notice as you make transformation from normal glucose tolerance to type 2 diabetes, there is a significant increase in coronary artery disease. And this is something that all of you have seen this many, many times, that a patient who has diabetes and coronary artery disease has a very low probability of survival compared to those who do not have diabetes and who do not have coronary artery disease. So the survival is dictated by the presence of both diabetes and coronary artery disease, and that is a very deadly combination. This is a study that was done called Mr. Fit, where they looked at the cardiovascular events in non-diabetic patients with hypertension and diabetic patients with hypertension. You will notice those patients who have diabetes and hypertension, there is a significant increase in cardiovascular mortality. So at the same level of blood pressure, there's a big difference between those who have hypertension and those who have diabetes and who don't. Now let us look into the pathophysiology, why patients with diabetes are so vulnerable to cardiovascular disease. And this is a slide showing 24-hour blood pressure pattern in patients who have normal blood pressure or high blood pressure, and those who have diabetes and who do not have diabetes. You will notice those individuals who have diabetes, they do not reduce the blood pressure at night time. That means they continue to have nocturnal hypertension. So one of the characteristics of vascular disease in diabetic patients is they lose this biological pattern. They continue to have nocturnal increase in blood pressure or non-dipping status, which might be one reason why patients with diabetes are at high risk for cardiovascular disease. You will notice here, both in normotensives and hypertensive diabetics, they do not dip the blood pressure as much as those who do not have diabetes. So one thing you have to keep in mind is that diabetic patients with or without high blood pressure, they do not have nocturnal fall in blood pressure. Now, I do not want to go into the goals of blood pressure reduction in diabetic patients. Now, I think there is a reasonable consensus, despite some debate and discussion, that if possible, you should try to reach a blood pressure close to 130 by 80. And this is a study called Hypertension Optimal Treatment Trial, comparing diabetic patients with non-diabetic patients. You will notice the best survival was in patients whose diastolic blood pressure was less than 80. You know, there is some controversy, 80, 85, 80, 84, but let's not worry about it. As long as you have diastolic blood pressure close to 80, and that is the best marker of better prognosis. Now let us look into the pathophysiology, why these our diabetic patients are more vulnerable for cardiovascular disease. This is sympathetic activity as measured in the nerve, muscle sympathetic nerve activity in normal individuals shown in the yellow color, patients with hypertension shown in the orange color, and that brown color is a combination of hypertension and diabetes. You will notice once you have hypertension and diabetes, there is tremendous activation of sympathetic nervous system. So the second pathophysiological mechanism for vascular disease in diabetics is activation of sympathetic nervous system in those patients who have chronic diabetes and hypertension. Now let us look at the endothelial function in individuals with diabetes. All of you know the normal function of endothelium is to cause vasorelaxation, and the vasorelaxation occurs because of the availability of nitric oxide. So nitric oxide availability causes vasodilatation, but diabetic patients have reduced endothelial function. They are unable to vasodilate. And this is a slide showing that in diabetic individuals, you will notice at the right side, they have increased vasoconstriction or lack of vasodilation because of loss of endothelial function. This is a very interesting slide I would like for you to see. And this is how the normal endothelium looks like in a photomicrograph. In a photomicrograph, this is how the normal endothelium looks like. That means it's a barrier. It does not allow any constituents of the blood to enter into the blood vessel. So the normal endothelium is like a gate. It's a gating mechanism. It prevents protein, it prevents platelets, it prevents fibrin, etc. from going into the blood vessel. And this is normal endothelium. Now let us look at the endothelium in individuals who have diabetes. You will see here the endothelium is completely disrupted. Instead of becoming smooth and silky, now it becomes like as if it is like a Velcro. So imagine when you have silk, nothing gets attached to it. But when it is Velcro, everything gets attached to it. So the endothelium, which is supposed to be silky, becomes like a Velcro in diabetics. That means it allows platelets to be aggregated, it allows fibrin to be aggregated, etc. And this is a slide showing that what happens to the blood vessel that is normal, shown in the blue color, compared to diabetic. You will notice in the normal model, when you give acetylcholine, there is vasorelaxation. In diabetic model, there is no vasorelaxation at all in response to acetylcholine. That means a diabetic individual is more prone to vasoconstriction due to lack of availability of nitric oxide. And this is how normal endothelium looks like, and which prevents the platelets and fibrinogen from entering the blood vessel. But now look at the endothelium in a diabetic individual where there is disruption of the barrier. All the proteinaceous materials, platelet, fibrinogen, fibrin, all of them migrate from the blood vessel into the blood vessel from the bloodstream due to the loss of endothelial function. So one of the characteristics of diabetic individual is loss of endothelial function, lack of nitric oxide, increased vasoconstriction. This is a human study looking at forearm blood flow in a normal individual control compared to diabetic individual. You will notice in a diabetic individual, there is a significant decrease in forearm blood flow compared to control subject. That means they have vasoconstriction or lack of vasodilatation. So one more mechanism for vulnerability of diabetics is decreased vascular responsiveness to nitric oxide and greater vasoconstriction. This is a very beautiful slide. I want you to look at attention in coronary artery disease with a PET scan. This is look at myocardial blood flow with a PET scan in people who have normal insulin sensitivity or people who have insulin resistance. You will notice in the presence of insulin resistance, there is no coronary vasomotor tone. The vasomotor tone of coronaries is significantly blunted in the presence of diabetes, whereas vasomotor tone is preserved with normal insulin sensitivity. Very beautiful slide showing that patients with diabetes have problems with coronary vasomotion and therefore they develop coronary vasoconstriction. Now let us look at another pathophysiological mechanism why diabetics are so vulnerable to vascular disease. And these are the histological specimens of the kidney from normal individuals and patients who have diabetes. You will notice in individuals with diabetes, there is increased activity of angiotensin converting enzyme and increased activity of angiotensin in comparison to normal individuals. So the kidney of a diabetic individual has increased activity of the renin-angiotensin system. There is increased aggregation of angiotensin within the kidney and shown beautifully in this slide in comparison to normal individuals. So that is the reason why diabetic patients respond much better to RAS inhibitors, because there is exaggerated synthesis of renin-angiotensin system in the kidney of diabetic individuals. Now, blood sugar itself is a stimulator of renin-angiotensin system. This is a study showing how angiotensin levels increase once the blood sugar starts going up. So one of the activators of the renin-angiotensin system is blood sugar. We always think of salt, volume, etc. But do not forget, in diabetic individuals, glucose is a very powerful stimulator of renin-angiotensin system. Now let us look at central aortic blood pressure during daytime and during nighttime in diabetic individuals compared to control. Diabetic individuals on this slide are shown in the green color. Normal controls are shown in the orange color. Central aortic blood pressure is high in diabetic individuals both during daytime and nighttime. That means they have persistent, uncontrolled hypertension. It does not matter what you measure in the arm, but the central aortic blood pressure is significantly increased during daytime as well as nighttime. And this is another reason why diabetic patients are so vulnerable to vascular disease. Now, just for 3 to 5 minutes, I want to discuss the so-called molecular basis of vascular disease in diabetic individuals. As you know, hyperglycemia and insulin resistance, they activate oxidative stress, they activate protein kinase C, they activate RAJ. Once you activate oxidative stress, you cause vasoconstriction. Once you stimulate protein kinase C activation, you cause inflammation. And once you increase RAJ, you cause thrombosis. So diabetic individuals have hyperglycemia, high free fatty acids, and insulin resistance. All these three mechanisms cause oxidative stress, which results in vasoconstriction, inflammation, and thrombosis. And this is the molecular basis of vascular disease in diabetic individuals. Now, there are pathways of superoxide generation in diabetic individuals. As all of you know, the glucose is metabolized by various pathways, which results in advanced glycation end products, increased protein kinase C, and once you have advanced glycated end products and increased protein kinase C, there is superoxide generation that causes vascular disease. And one of the other mechanisms appears to be fructose. Ultimately, advanced glycated end products might result in the formation of fructose, and fructose is a very powerful vasoconstrictor, and that is one more mechanism by which diabetic patients are so vulnerable to vascular disease. Advanced glycated end products ultimately cause increase in vascular smooth muscle hypertrophy. They cause macrophage infiltration. They cause extracellular matrix deposition, and they cause endothelial damage. All of them result in atherosclerosis. So the presence of advanced glycated end products can cause significant structural and functional changes at the blood vessel. So this is the molecular mechanism that I'm summarizing, that I have described in the last 2-3 slides, that increase glucose directly or indirectly through its other intermediary projects, fructose, sorbitol, etc., causes oxidative stress and activation of protein kinase C. And when you have oxidative stress and protein kinase C activation, there is smooth muscle hypertrophy and endothelial damage. And this is a summation of what I have discussed so far, so-called molecular basis of vascular disease in diabetic individuals: increased glucose resulting in atherosclerosis, increased advanced glycated end products resulting in atherosclerosis, increased protein kinase C resulting in atherosclerosis. So whichever way you look at it, whichever cards you look at it, all of them lead to atherosclerosis through glucose, through advanced glycated end products, and through protein kinase C. And this is supposed to be the molecular mechanisms of atherosclerosis in diabetic individual. Now, this I have already discussed. Diabetes, in addition to special characteristics that I have shown, like nocturnal blood pressure, endothelial damage, molecular mechanisms, central aortic BP, diabetic individuals also can have conventional risk factors such as hyperlipidemia, C-peptide, thromboxane A2. All these conventional risk factors are also present in patients who have diabetic individuals. Very important reason why diabetic patients are prone to atherothrombosis is they have increased activation of platelets. The platelets in individuals with diabetes are very angry. They're extremely angry, and angry platelets stick to each other. And once they stick to each other, they cause the process of atherosclerosis. So ladies and gentlemen, hypercoagulable state and increased platelet aggregability is an important pathophysiological mechanism for vascular disease in patients with diabetes. And that is the reason why most of the guidelines recommend antiplatelet drugs to protect diabetic vascular disease, because these platelets are very angry, they're very mad, they're very agitated, and you have to calm them down so that they don't cause vascular damage. So lastly, Dr. Sabu, ladies and gentlemen, and Mr. Chairman, This is a nice study showing from Harvard, looking that the blood pressure actually starts going up in diabetic individuals before you make the clinical diagnosis of diabetes. Actually, there is a rise in blood pressure in diabetic individuals 20 to 30 years before you make the clinical diagnosis of diabetes. For example, you are making the diagnosis of diabetes today, the patient probably had hypertension for last 20 to 30 years. That means these things come as a package: diabetes, hypertension, hyperlipidemia. Which comes first is not known, but they come as package. Very important to know that hypertension precedes the clinical diagnosis of diabetes. Similarly, HDL cholesterol. Low HDL cholesterol, which is a hallmark of diabetes, is seen 20 to 30 years before you make the clinical diagnosis of diabetes. That means dyslipidemia, like hypertension, precedes the clinical diagnosis of diabetes. All of you are wonderful diabetologists. You're great practices. You're pleased when you make the clinical diagnosis of diabetes. But on the other hand, they already have other risk factors before the clinical onset. Lastly, same thing, triglycerides. You will notice hypertriglyceridemia occurs much before the clinical diagnosis of diabetes. So hypertension, low HDL, and hypertriglyceridemia precede the clinical diagnosis of hypertension. So, Mr. Chairman, ladies and gentlemen, Dr. Sabu, and those who have attended the program, I have given you a very fast, like an expressway, mechanisms of vascular disease in hypertension very, very quickly. In the beginning, I suggested hypertension and diabetes together increase cardiovascular risk, and I have shown you the data. And I have shown you the data. The worst survival is in patients with diabetes and coronary artery disease. I showed you that patients with diabetes, they have continuous nocturnal hypertension. I've shown you that patients with diabetes have increased central aortic blood pressure day and night, even if they have normal blood pressure. I have shown you that diabetic patients have endothelial dysfunction. I have shown you diabetic patients have decreased coronary vasomotion in human beings. Then I have showed you the 4 pathways by which they have increased atherosclerosis, molecular basis, including platelet aggregation. I have shown you that the triad of multiple risk factors in diabetes, they precede the clinical diagnosis of diabetes. And that is the reason why when you see patients with risk factors, you have to screen all the risk factors, not wait for one thing to come, etc. And once you have a diabetic patient, you have to provide what is called as comprehensive cardiovascular care. Now, glycated hemoglobin is fine, proteinuria is fine, blood sugar is fine, but you need to go beyond it and treat the person to prevent the onset and progression of cardiovascular disease. In the time that was allocated to me, I gave you gross mechanisms, physical mechanisms, chemical mechanisms, biophysical, and biological mechanisms responsible for making diabetic patients so vulnerable for vascular disease. With those remarks, I offer my gratitude and salutation to the organizers, and thank you for asking me to participate.